Hi, this is Joe Schwab, and if you recognize my voice, it's probably because you've heard another episode of the AHF podcast, which means you're listening again. And I can't tell you how much I appreciate that. And because you're listening again, I want to ask you a favor. If you could share this podcast with a colleague or a friend or somebody you think might be interested in this type of content, or better yet, leave us a review on your podcast platform, or give us 5 stars, or you could do all of those things. We really appreciate it, and it helps us grow. Anyway, thank you so much for being a listener and a subscriber to the AHF podcast. Now let's get on with the show. Welcome to the AHF podcast. I'm your host, Joe Schwab. I've said it before and I'll say it again. One of the reasons we host these great debates is because surgeons are at their best when they disagree passionately, and at their funniest when props start coming out during the opening statement. Today's topic is one of those questions every hip surgeon wrestles with. Do we really need to optimize obesity before an anterior hip replacement? The pro position is Dr. Nicholas Weber, a tumor surgeon, an anterior approach convert, and a self-described, quote, immensivist, and apparently proud owner of an alpaca named after me. I didn't know this before the debate, and I'm still kind of processing that. Opposing him is Dr. Todd Kelly, who heard no slides and decided that meant yes, props, including but not limited to pants, coins, a fake panis, and a demonstration that I think will live in AHF history. If you've ever wondered what happens when serious surgical philosophy meets a kindergarten pep talk about doing hard things, this debate is your answer. Let's get into it. I'd like to call to the stage Dr. Nicholas Weber and Dr. Todd Kelly, who has come with some props.
You said no slides.
No slides, but I didn't say anything about no props. All right, position statement. Obesity, this is like a double negative kind of thing. Obesity does not need to be optimized prior to anterior approach. The pro position, Dr. Nicholas Weber, likes them big, right?
Likes them big.
That's what you're saying.
And chunky.
Okay, and the con position, Dr. Todd Kelly, Dr. Weber.
You guys don't know me, so I'm going to tell you about my journey a bit. While I'm telling you about that, because you may not care, I want you to think of your 3 most appreciative patients. The one that brought you the most tamales, the one that brought you the most chocolate chip cookies, the one that gave you the biggest, fluffiest hug you've ever had in your life. Think of those, and I'm going to introduce myself. I'm a tumor surgeon. I started doing joint replacement when I started a tumor program at a big hospital, and of course he imported me from Wisconsin to give this talk just to kind of poke more at Wisconsin. When you start a sarcoma program, everything's a tumor. 160-pound panis, tumor. A butt that's dragging behind in a wheelchair, tumor. Absolutely perfectly fine. Every older partner I had called me the immensivist. Perfectly fine being the immensivist. So when I got to starting my practice, I said, okay, I'm going to do everything. That's what everybody says. And I did everything. So part of everything is doing everything that people don't want to do. For 15 years, I became this end-of-the-road type of surgeon. All posterior for 10 years. So I've been there. Ben Dom came and gave a talk at Aurora and said, there are all these outliers in the posterior approach. I stood up and said, you don't do anyone with a BMI under 25, or excuse me, over 25. He said, absolutely, yes, I do. I made all these excuses for doing the anterior approach. 3 times I tried to do the anterior approach in my patient population, which is a BMI of who knows, and I'll tell you a little bit about that. The first time, bloodbath. I don't know what I'm doing. Why am I a tumor surgeon doing something that's so difficult? Second time, okay, I'll do this. I stayed up all night thinking of my anterior approach the next day, and I said, why did I think about that? And my osteosarcoma resection, I didn't think about. Forget it. My one kind of take home to those of you who are posterior surgeons, have someone come and visit you, teach you how to do an anterior approach. Someone did that to me, changed my life, and I'm going to really get into things. I have an alpaca at home named Joe Schwab. Not necessarily because Joe Schwab helped me do that, but he may have. So, to the question, I don't know if you have a kindergartner. In kindergarten, they say, can you do hard things? I changed from being a pure orthopedic surgeon to a dad, and I want my kids to know you can do hard things. We have more and more literature saying, yes, there are still complications with obese patients. However, is their patient satisfaction the same? Yes. Is it better? Maybe not. Do we have problems with incisions? Absolutely. Do we have problems with incisions in little old ladies who have really thin skin? Do we have problems in women who have had C-sections? 100%. There are problems. Is that a reason to say obesity needs to be optimized? What does that even mean? Think of a BMI of 37, big, strong construction worker. Think of a BMI of 47, someone whose belly you can tape to the side, do a perfect approach. I don't have a problem doing any of that. We can change their BMI. We can change all the controllable factors. But in real life, does it need to be optimized? The answer is no. And Dr. Kelly, you and your kids, they can do hard things.
4 minutes.
All right, sir. We're going south side Chicago on you here, right here, right here. All right. Tell a little story first. Medical College of Wisconsin. I'm on an interview for residency. Interviewer asks me, hands me a sack of coins, says, reach in there, count up, tally up those coins. I say, all right, start doing it. And the idea is, okay, you got to figure out what you're doing with your hands. You've got to communicate. You got to think all at the same time. So I'm going to challenge you to let's do this anterior style. Come on over here. These are my pants. They're relatively clean. I want you to reach in my front pocket there and count up those coins and tally them up, and let's see what you get. Now, all you guys are thinking, where's he going with this, right? No, you can't look at it. We're doing hard things here. We're doing hard things. You got to feel it. You got to feel it. You got to feel it. What do you got there? Come on, I only got 4 minutes here.
We got a quarter here, 50 cents.
You're too slow.
65 cents.
60, brilliant. You can count, you can do math. All right. Here we go. Now this pair of pants here, there's a little extra tissue in here. You can just throw these on the floor. I'll clean it up. I'm going to ask you to reach in and do that same task anterior style. Now, while you're doing that, I'm going to tell another story here. Early in my career, I go to a MATA course, and I ask MATA, hey, I need some advice on obese patients. How do I navigate this? And Dr. MATA, he's pretty blunt. He says, yeah, just tell them they're too fat, they'll go away. Right? So that didn't work for me. So here's my discussion with obese patients. You doing okay? Yeah. Here's my discussion with obese patients. I say, listen, we're going to do a good job for you, but I need you to help me help you, right? We ask smokers to quit smoking. We ask diabetics to work on their blood sugar. I tell them, hey, we're going to do a good surgery for you, but I ask you to lose a little bit of weight. Let's come back in a couple of weeks, and we'll see where we're at. Plenty of research out there that looks at, oh, you know what, I forgot the pannus here. We're going to hang this pannus up here too. All right? Now you mentioned you can get through this pannus here, right? So core study 2023 looked at how low that pannus hangs on an x-ray. Higher risk of wound complications, higher risk of infections, higher risk of fractures when there's a pannus in your way there. And just tape that up and out of your way. You can just tape that pannus up. You just keep working there. And so plenty of research that looks at higher risk of infection, higher risk of DVT, higher risk of fracture in obese patients if we don't. And we're just talking about modifying, we're just talking about optimizing them. And I think it's really important to say here, optimizing their care is not delaying their care, it's not denying them care, it's just ensuring that they have a good outcome, all right? My second point, the reason I'm doing this is to show you that yes, this is hard, and yes, we can do hard things, but I don't think we can do our best at it, right? I mean, I don't know that you even found a coin in there. Oh, I certainly did. Right? So you know, this is hard, and I think we can make errors if we're not optimizing our patients. The other thing is you know, there's a lot of research out there that looks at, you know, we know joint replacement surgeons, there's a high physiologic load. Doing obese anterior approach, higher orthopedic load on us. So I think you have to think about yourself here a little bit too. These are tough to get through.
1 minute rebuttal.
So here's what happens when you tell patients to optimize their body mass index. What happens is they diet, they go on Wegovy, and what happens is this. Their pannus goes away, right? Everything that you need to get out of your way to do an anterior approach goes away. 100% it does not. If their pannus hangs to their knees, my wife is here, and I love her. And we drive by this farm every day, and this guy's pannus, he hangs down to his knees. I made him lose weight. I did the 10% thing, and he did. And I think he lost it from his shoulders. So I'm almost positive, I want to optimize body mass index, but it's not necessarily optimizable. You have to treat these patients. I have to treat patients with osteosarcomas if their BMI is 70. We're in a similar situation. There are people that are just as debilitated by their arthritis as they are by their osteosarcoma in one way or another. We got to do what we got to do.
1 minute rebuttal.
I'm going to take you through another scenario. You got two patients. One patient comes into your office, their BMI is 40, and they say, "Doc, you got to help me. Give me some pain meds, do my surgery. I need to get this done." And I give them that same conversation, come back in 2 months, lose weight. Their BMI starts at 40. I got another patient whose BMI comes in at 42, and I give them that same instructions. Now this one comes back with a BMI now of 40. So now they're both at 40, right? Which one do you think is going to do better with that surgery? Same otherwise. I think if you plug that into Christoph's algorithm, you're going to see that this patient who did lose some weight and optimized their care does a little bit better. And the reason is the psychological term for that is called locus of control. One has an external locus of control. They want someone else to do something for them. The other has an internal locus of control. They are able to kind of take control and do some things for themselves to get them in a better position to do well with that surgery.
Thank you, gentlemen. Excellent debate. Excellent.
For all the humor in this debate, and there was a generous amount, including a live demonstration of anterior approach coin retrieval through 2 layers of pants, both Dr. Weber and Dr. Kelly were wrestling with the same fundamental question. How do we give high-risk patients the safest path forward without judging, delaying, or abandoning them? Dr. Weber reminded us that some patients just need someone willing to take on a hard case. Dr. Kelly reminded us that asking patients to participate in their own optimization is part of compassionate care. And both of them reminded us that pannus height apparently matters more than any of us learned in residency. No matter which side you lean toward, it all comes back to the patient, their pain, their goals, their effort, and yes, maybe even their sense of humor. Thank you for listening to this episode of the AHF podcast. As always, please take a moment to like and subscribe so we can keep the lights on and keep sharing great content just like this. Please also drop any topic ideas or feedback in the comments below. You can find the AHF podcast on Apple Podcasts, Spotify, or in any of your favorite podcast apps, as well as in video form on YouTube/@Anterior Hip Foundation, all one word. Episodes of the AHF podcast come out on Fridays. I'm your host, Joe Schwab, asking you to keep those hips and pannuses happy and healthy.